Hi, good night, everybody. Thank you so much for joining us. This is Thyroid Management Made Easy webinar presented by People's Choice Compounding Pharmacy. My name is Brandy Kinnear. I'm the Director of Business Development for the pharmacy. And we thought we would put together this webinar to help bridge what we consider to be a bit of lack of information for naturopathic practitioners in Ontario on how to manage thyroid. So we hope you find this valuable and useful in your practice. Just a bit of housekeeping, there is a link at the bottom here that will take you to the free Facebook group that we've created. This is a pre-recorded webinar. However, we do have the free Facebook group where we will be live. Ihab Mikhail, the pharmacist and presenter, who I'll introduce shortly, will be there to answer your questions and ongoing for support for anything that you might need. He is also available by phone if you'd like to call him directly at the pharmacy for any patient questions or concerns or general information you're looking for in regards to bioidentical hormones or compounding. Of course, 905-770-3113. And now I'd like to introduce Ihab Mikhail, pharmacist trained by both the A4M and the PCCA with over 15 years of experience working with both integrative practitioners and naturopathic doctors on bioidentical hormones. Ihab, take it away.
Hello, good evening everyone. Thank you for joining in and thank you for taking out the time. Thanks for the introduction, Brandy. My name is Ihab Mikhail. I'm the compounding pharmacist here. We are hoping during this webinar will shed some light on the ambivalent topic of thyroid management. It is a big topic, but we'll try to make it not so long. And as Brandy mentioned, I'm looking forward to meeting you on the Facebook group. My goal tonight on the topic is to give you some knowledge, to empower you, to be able to service and ready for this seemingly constant influx of thyroid patients. So let us get started. So tonight we are going to talk about the metabolic approach to thyroid hormone replacement. So our goal tonight to learn about clinical symptoms of hypothyroidism and Hashimoto's. Also to know the factors that cause decreased production of T4 and the factors that cause the inability to convert T4 to T3. Also we'll talk about the testing, blood and urine testing, and what kind of testing we'll be looking for. And we will end off with the treatment, how to treat hypothyroidism. So as most of us know, thyroid hormone, there are few types of the thyroid. T3 and T4, they are the most common types. T3 is the active form of thyroid, and the T4 is the prohormone. There is plentiful of T4, but T4 eventually will convert to T3. T1 and T2, they are again another type of thyroid. We will highlight the thyroid pathway in a simple way. So simply, hypothalamus will secrete the thyroid releasing hormone that will stimulate the pituitary gland to release the thyroid stimulating hormone, and the thyroid stimulating hormone will stimulate the thyroid gland to release the T3 and T4. Again, T3 is the active form, and T3 is found in the tissues. The main organs are heart, liver, bone, CNS, and thyroid gland as well. T4, again, it converts into T3 in both ways. In some cases, T4 sometimes converts to reverse T3, which is undesirable conversion because reversed T3 is not active and it occupies the receptors of T3, so it makes really the therapeutic effect of T3 is not found. We'll talk about the signs and symptoms of low thyroid. This is a true statement, which the earliest signs and symptoms of low thyroid function can occur several years prior to the lab studies being abnormal. And the reason for that is the normal ranges for serum TSH are quite broad. Most laboratories consider 0.35 to 5 to be normal. And even some physicians will not treat thyroid unless the TSH around 10. However, a British study showed that TSH above 2 is associated with increased risk of developing hypothyroidism later in life. Thus, many instances of hypothyroidism could be missed because of the range is so broad and because of the importance of having low TSH is overlooked. Now, some estimates they are saying about 2 million Canadians may have undiagnosed thyroid disease. That includes the hypothyroidism and hyperthyroidism. The majority will be hypothyroidism. There are certain signs, most probably you are aware of some of them and symptoms. Even the patient as they walk through your door will know most probably they will have thyroid imbalances, but we'll go over a more comprehensive list of symptoms and signs for low thyroid, such as swollen legs, feet, hands, abdomen, insomnia, fatigue, very common, low body temperature, including the cold extremities and poor circulation. Weight gain is very common too. And infertility. Most of the infertility clinics, they do use thyroid treatment as part of their treatment for infertility. PMS symptoms, miscarriage, endometriosis, hyperinsulinemia, fibrocystic breast disease, and as you see here, they sound like PCOS syndrome, which is polyovarian cystic syndrome. Depression. Risk of depression is 4 times greater for elderly patients suffering from subclinical hypothyroidism than from overt hypothyroidism. An anxiety attack, loss of memory and cognitive function, general slowing of mental function is another feature of hypothyroidism, ADHD, and agitation and irritability. ADHD, there are some studies about ADHD and memory, cognitive function, and depression linked to hypothyroidism. We will go over it on the later slides. Poor circulation, as we said, cold intolerance, cold hands and feet, dry hair, and dry skin as well. Yellowish discoloration of the skin because of the inability to convert beta carotene into vitamin A. I had an incident a few weeks ago. Somebody came in with a yellowish skin and eyes, and she went to her doctor. She got into, he stopped her from taking any vegetables and fruit that have beta carotene, and her liver enzyme was high. After he ruled out anything with the liver function, and they did ultrasound and so forth, put her on thyroid, and the issue has been resolved. The elbow keratosis, nails that are easily broken, and hair loss. Also, low thyroid is linked to, of course, arthritis, pain in joints and muscle, morning stiffness, carpal tunnel, fibromyalgia, puffy face, osteoporosis, but in a different manner. So the bone structure can become abnormally thick and weakened at the same time, and headaches. We have quite few pain clinics, and they also implementing the thyroid management along with the pain management at the same time to improve the outcome for the patient. Poor night vision, loss of the outer 1/3 of the eyebrows, and that's common in hypothyroidism, loss of eyelashes and thin eyelashes, dizziness, vertigo, dry ears, scaly and itchy ears, excess wax formation. If you have people are diagnosed with low thyroid, you also got to check on the iron, especially the ferritin levels, and vitamin B deficiency. With the low thyroid, also gallstones, bladder and kidney infection, impaired kidney function, mild elevation of liver enzymes. There is multiple studies that link the low thyroid with the cardiovascular risk. So some studies suggest that total cholesterol rises incrementally with rises in TSH, while others refute that finding. C-reactive protein and homocysteine levels are increased in hypothyroidism. Blood pressure is also often elevated. These laboratory changes are markers of increased of cardiovascular disease risk. Of course, the reduced heart rate and the arrhythmia, those are very common with hypo and hyperthyroidism. Erectile dysfunction for men, low libido and decrease in sexual interest in both men and women. There are some studies I put here for your record about the link between ADHD and thyroid hypothyroidism. Again, studies show that ADHD is very common among individuals with resistance to thyroid hormone. Again, there is another study, hypothyroidism is a risk factor for cardiac disease or cardiovascular disease. Congestive heart failure and thyroid function, low ratio of T3 and reverse T3 is predictor of mortality on congestive heart failure. There is a good study. I got a phone call from one of the naturopathic doctor, again not long ago, about an elderly patient. She is fragile and she was congestive heart failure patient. And there was hesitation to put the patient on desiccated thyroid. However, with the studies and the evidence, I would say it will help if you put the patient on the desiccated thyroid. It will help even in her cardiovascular risk, to decrease her cardiovascular risk. I would like to just highlight quickly the ratio between T3 and reverse T3. I know that's not a very common practice, but I'm going to say just one statement. This ratio is supposed to be either 20 or higher than 20. Lower than 20, you have to treat the patient as having a reverse T3, and we will get into this in a further slide. Thyroid function with the arterial stiffness. There is a study being done on women. It increases the arterial stiffness if the patient having low TSH. Homocysteine, again, it's a marker for MIs or myocardial infarction or heart attacks. Homocysteine levels are commonly elevated in hypothyroid patient. The C-reactive protein, we talked about it, but there is a study to support that elevated C-reactive protein levels are associated with hypothyroidism. So you see really a big link between the low thyroid levels and the cardiovascular health. Here are some studies on memory. Again, there is one study done looking at the TSH levels and free T4, and they revealed that with the high TSH levels and low free T4, there is an attention issues. There is another study conducted on the free T4 levels, and when it's low, there is a language issues. There is another study done on the insulin resistance and lower TSH, higher T4 associated with improved insulin resistance sensitivity. We'll talk about how to test. What are we looking for when we send the patient to test for their thyroid? There are a few things we can test for the thyroid function. The first is TSH, free T4, free T3, reversed T3, anti-thyroglobulin antibody, TPO, and iodine. Now, if you don't want to do all of them, I would recommend at least 4 of them. TSH, free T4, free T3, and the TPO. Now, if the patient comes back with a high TPO, and when we say high TPO, it means the patient is Hashimoto's patient. That means he has an autoimmune disease. So I would recommend to go for further testing for iodine. And I will tell you why in another slide. But briefly, iodine, it's helpful in most hypothyroidism conditions, except in Hashimoto's patients. The majority, they will benefit out of the iodine. However, some of them, they will make the Hashimoto's symptoms worse, and the reason we'll discuss it later. So the lab testing, there are 2 testing available on the market. The most common one is the blood, and I believe the blood is sufficient for benchmark and also sufficient to give us good indication on the patient status. The urine, it's a 24-hour collection of urine, and they test the thyroid in the urine. The advantage of the urine, they claim they test the thyroid in the tissues rather than the thyroid in the blood. However, I believe the common practice is the blood testing. Again, we all, or the majority of us, know that the T3 is the active form of hormone. T4 is the prohormone. T4 converts into T3. This is a very important statement. The transporter for T4 is more energy dependent than the transporter for T3. So what happens is the T4 in the blood, sometimes the levels are high. However, there is no enough T4 is transported to the tissues because the energy is not there. So if a patient has any mitochondrial dysfunction, you have to look and treat and fix the mitochondrial dysfunction in order to help the T4 to get transported into the tissue and also to get converted into T3, because if it's not transported, it will not be converted. So we'll find sometimes T4 is high, but T3 is low. There is numerous reasons for this, but one big reason is if the patient has mitochondrial dysfunction, we need to work on it in order to bring the T4 into the tissue in order to be converted to T3. We'll talk about the conversion from T4 to T3. It's very important. There are numerous things, again, and reasons why the inability to convert T4 to T3. One of them is diet. Another thing is the medication. If a patient on a conventional medication, and other things, which is factors we have no control on, and some other conditions we'll talk about very briefly. For the diet, I would like to highlight, sometimes we do a weight loss program at your offices, and we put the patient on veggies, which it is a healthy alternative. However, we got to be conscious that the cruciferous vegetables, broccoli, cauliflower, they inhibit the thyroid function and they hinder the weight loss. Also, the very low carbohydrate, because it's very common with the weight loss programs that we have on the market, that we put the patient on a very low carbohydrate diet. Again, it inhibits the thyroid and it sluggish the weight loss program. So patients on the weight loss, but they're not losing as they wish. excessive alcohol use as well, and soy. They are among many of the factors that makes the T4 not easily converted into T3. This enzyme, which it's called 5-deiodinase enzyme, this is the enzyme that converts T4 to T3. There are three types of this enzyme. Type 1 and type 2, they are good types. That means they convert T4 to T3. However, type 3 of this enzyme, the 5-deiodinase, it converts T4 to the reverse T3, which is undesirable conversion, as we said before. The elements that affects or inhibits this enzyme is the inflammation. There is study done on this. Selenium deficiency, stress, heavy metal toxicity, starvation, inadequate protein intake, decreased kidney or liver function. They are all very important. We will talk about most of them again and again, especially selenium deficiency. We tend to recommend selenium for the majority or vast majority of the hypothyroidism patient anyways. It's a good addition in different direction, but we'll talk about it. Another reasons, aging, excessive alpha lipoic acid. I would say anything above 1000 milligram of alpha lipoic acid, it might hinder the conversion from T4 to T3, diabetes, fluoride, pesticide, and radiation. As we said before, medication. So if a patient on a beta blocker for different reasons, like propranolol, bisoprolol, atenolol, or nadolol, anything ends with olol, that's a beta blocker. Birth control pills, lithium used for psychiatric medication or psychotherapy, phenytoin for seizures, theophylline for asthma, and chemotherapy. They are all medication can hinders the conversion from T4 to T3. Now we'll talk about what can we do to improve the conversion from T4 to T3. Selenium, again, my recommendation for selenium is 200 to 400 microgram, or let us say 100 to 400 microgram. If the patient is Hashimoto's, which again, the TPO, which is the antibodies, is high in their blood or urine, we like to give the selenium in a higher concentration. I would say maybe anything between 600 to 1200 microgram. We've seen great success in dropping TPO only with gluten-free diet and selenium around 600 to 1200 milligram after 3 months. Potassium, iodine, iron, zinc, high protein diet, and ashwagandha. Ashwagandha is good in the conversion, but also it's good because it increases the T4 levels in the blood. Some doctors, they use insulin to improve the conversion, melatonin, anything between 3 to 10 milligram a day, and tyrosine. Treatment. We'll talk about the treatment of hypothyroidism. You get, and we get lots of phone calls from naturopathic doctors talking about patient is on L-Troxin or Synthroid, want to convert into desiccated thyroid. So what is the difference between L-Troxin and desiccated thyroid? Desiccated thyroid has both T3 and T4. L-Troxin is only T4. Study after study showed that the combination of T4 and T3 is needed to normalize levels of T3 in the tissue, which is more important. Another study concluded that therefore it's not appropriate to use T4 alone for the thyroid replacement therapy, especially if a mitochondria, again, dysfunction is found. So the most common thyroid medication is given, desiccated. It's derived from porcine or porcine. It's from the pig. It has T4 and T3. Why we are giving T3 and T4? Two studies we showed that we have to give the combination, but also the logic behind it. The T4 has long half-life. So T4 half-life is 6 days. The T3 half-life is only 18 hours. So while we are giving the T3 to give the therapeutic effect, the T4 is at work to give a long-term effect while the T3 is giving a short-term therapeutic outcome. What is the dose we should start with? Again, dose depends on the clinical manifestation or presentation. Initial recommended dose is 60 milligram, 1 tablet in the morning on an empty stomach, and titrate as needed. Now, the ideal physiological dosing is twice a day, morning and around 4 o'clock. However, because of the patient compliance, we start with one dosing only, which is in the morning, 60 milligram. And the dose titration goes like you up titrate or down titrate by 15 milligram according to the symptoms. It is important to educate the patient who you are going to prescribe desiccated thyroid about the signs of hyperthyroidism. And I hope that you all know about the hyperthyroidism symptoms. The most common one will be sweating, heart racing or palpitation, shortness of breath, and so forth. If the patient gets one or more of those symptoms, they need to titrate down again by 15 milligram. Always we encourage to incorporate enough selenium and zinc and iodine. So selenium, I would say anything between 100 to 400 microgram, zinc anything between 10 to 50 milligrams, and iodine, there are two different types of iodine. We'll talk about them later on. But again, iodine, if the patient has high antibodies, you got to measure for iodine before you supplement iodine. Follow up always in 8 weeks. I would say 8 to 12 weeks, 2 to 3 months. Again, continue titrating up or down by 15 milligram until achieve optimum result. So a patient comes in, you're given an initial prescription for 60 milligram of desiccated thyroid. Is not enough. You want to increase, you increase by 15 milligrams, so it becomes 75 milligrams. If the patient comes in with the follow-up visit and it's too strong, you titrate minus 15, it will be 45 milligrams. Again, thyroid should be taken on an empty stomach. It says here 1 hour before or 1 hour after eating. We tend to tell patients like 30 minutes before or after is fine. However, if the patient is taking any supplements or vitamins that contain calcium or iron, or they have food that has calcium or iron in it, we recommend at least 3 hours apart between the thyroid and the calcium and iron containing supplement or food. Very important, we talked about how if the patient has a mitochondria dysfunction, the T4 will not be transported properly. The reverse T3 will found high in their testing. In this situation, we work on the mitochondrial dysfunction. This protocol, I find it helps a lot. Magnesium elemental 400 milligram, we like the magnesium glycinate for bowel movement issues. Unless the patient is constipated, we recommend magnesium citrate. CoQ10 300 milligram, we recommend to take it with an oil containing food. NADH 10 milligram 2 times a day. D-ribose, it's a type of sugar. However, it's good even for diabetic people. They take 15 to 30 grams a day. 15 grams, it means 1 tablespoon. So it's 1 or 2 tablespoons a day. Alpha lipoic acid, 2 to 300 milligram a day. L-carnitine, it's 2 grams a day, assuming their kidney function is normal. We will say a little word on the Hashimoto's. We talked about Hashimoto's lots. It's not actually a small number, but they saying about 70 to 75% of hypothyroidism patients, they are Hashimoto's. That means they have high antibodies. So that's why it's important to test for TPO always. The two things we mentioned before, which is number one, eliminate gluten dairy from their diet. And it is believed, as to the study in front of us, that celiac disease is being investigated as being associated with a Hashimoto's. That's why by removing the gluten and including the selenium, again in a high concentration, I would say 600 to 1200 microgram a day, will bring the TPO levels in about 3 months. Patients with hives have higher frequency also of Hashimoto's. We'll talk briefly about the iodine and iodide. It's a great supplement, Always we supplement with iodine and iodide at the same time. About 1/3 of the patients, that means 30% of the patients, they are on the medication for hypothyroidism. They can lower their doses by only giving them iodine and iodide supplementation. 72% of the world's population is affected by the iodine deficiency disorder. The two forms or most common forms for iodine and iodide is Lugol solution, or if you see the abbreviation SSKI, it's a supersaturated or saturated solution of potassium iodide. This is also called Lugol solution. So Lugol solution is iodine and iodide combined. Lugol solution dose usually 1 to 3 drops a day only in the morning. They can start with 1 drop, increase as needed. They can put it on any fluid, orange juice, water, or anything they like. Iodorol, it has 5 milligram of iodine, 7.5 milligram potassium iodide combined in 1 tablet. And the dose for iodorol, usually they give it 1 to 4 capsules a day. And when it is 4 capsules a day, you do it in divided doses, 2 capsules in the morning, 2 capsules at night. Takes about 3 to 6 months of the iodine supplementation before iodine saturation is reached. Now, we talked about if the patient is Hashimoto's, we got to test for iodine levels. We don't give it without testing, because again, as you see here, the iodine in this particular situation in some of the Hashimoto's, not all of them, some of the Hashimoto's patients, they will cause, or it will cause, elevated levels of iodinated thyroglobulin, which will prompt the immune system to react and cause inflammation. Research has found in certain areas of the world where is high dietary iodine content, it might result again in thyroid cancer or thyroiditis. As a conclusion, when we deal with a thyroid patient, we deal with different aspects of the thyroid to manage their thyroid levels. Their nutritional intake, their diet is important. Their prescription, which is the desiccated thyroid, is important. Their supplementation is important. Their heavy metal toxicity is very important. Their hormone function is very important. And above all, the stress is very important. So I would like to just highlight that the thyroid, one of the very important triad, thyroid, adrenal, and hormonal function system. Those three are overlapping, and when you deal with one, you have to deal with the other two as well. Most patients will require replacement not only with the T4, but as we mentioned, T3 and T4 to optimize function. We talked about the iron levels. There are some references here to support our presentation tonight. I hope that was beneficial, and we could shed some light on the thyroid management. And I'm looking forward again to seeing you and talking with you on the Facebook group.
Well, thanks again for joining us, guys. Just a little quick bit here before we go. We have a course that is called How to Add Bioidentical Hormones to Your Practice. Not sure if you are aware of it. However, it's typically sold for $169. It is presented by Sebastian Dennison, who is an educator for the PCCA. He's a trainer as well, and he trains pharmacy technicians, and he does also speaking engagements all across North America. He has done an amazing job for us creating the content for this course, and it really breaks down the A to Z comprehensive management of BHRT in your practice. There are 3 category A credits associated with this. Just to give you an understanding of what the course breaks down is the different hormones, what roles they play, how to assess patients, an in-depth look at different testing options. He goes into analyzing the results, dosing forms, options, how to prescribe, how to do follow-ups. There's a little bit of a mini course by me on how to add it to your practice from a marketing perspective, identifying your ideal client, marketing your services, and then some tech information. Many of your colleagues have taken the course. We've had amazing feedback. And what we decided we would do tonight is to offer you the course, anybody that's on this webinar for the next 24 hours, we are offering the course for 50% off. So there is a link below the webinar that will take you to the course. And as I said, for the next 24 hours, the course will be 50% off. And we hope that is of value to some of you who are looking for some more information on, how to add bioidentical hormones to your practice and having some resourceful support. Just to note, this course is online. It is video module based, as well as downloads for the slides. And you do have lifetime access to the course. So it is something that you can go back to time again. It does have templates for prescriptions, symptom forms, checklists, you name it, we've added it in here. So it's chock full of amazing stuff. We hope that is of value to you. We hope you've had a good time on the webinar. And if you have any questions, please join us in the Facebook group. We are there live now, and we will be checking in. Remember, you can tag EHAB, EHAB, Mikhail, MEKHAIL, or just leave your notes or leave your comments or questions in the Facebook, and we'll be there to help. Thank you so much. Take care. Bye-bye.